I request Dr. Rajiv Lochhan to felicitate the speakers and chairpersons. Now next we'll be proceeding for lamp lighting. I request all the EDPA executives, past presidents and past secretaries to kindly come near the dais for lamp lighting. I also request Dr. Neeru Agarwal. I request our chief guest Dr. Dinesh Khullar sir to kindly join us for lamp lighting. Now we will proceed to our next session, which is going to be the oration. I request all the EDPA executives, Organizing Chairperson, Dr. Neeru Agarwal ma'am, to kindly come over to the dais. Dr. Pankaj, Dr. Aman, Dr. Ajay sir, Dr. Paras, Dr. Vijay Arora, Dr. Sumer, Dr. Makkar sir, please. So this oration is dedicated to Shri Om Prakash Khare ji. This is our second oration. It was started in our previous MIDCON 2023. So Shri Om Prakash Khare Memorial Oration was instituted in the year 2023 by Dr. Lalit, one of the senior members and past president of EDPA, in the memory of his late father. Shri Om Prakash Khare was born in a small village called Sisoli near Meerut, UP in 1915. He was the eldest son of 5 siblings. His father was a farmer who had the forethought of educating his children, as he did not want them to endure the daily toils of farming. As a young man, he studied and acquired a job as an accountant in the government sector at Central Defense Accounts in Meerut. He eventually settled down in Meerut, married and began his own family, which included 6 children. Influenced by his father's thinking, he decided to strive for better education and opportunities for his own children, which he could not envision happening in Meerut at the time. So, he decided to shift his family from Meerut to Delhi. The problem was, he was unable to get his government job transfer to Delhi, so despite the dilemma of having a job in Meerut, he went forward with that endeavor. To make it work, he used to leave at 4 a.m. in the morning every day, as there was no other available transportation at that time. He would walk 10 kilometers from his residence to the old railway station, then travel standing on most days in the packed rush hour train to reach his office in Meerut at 9 a.m. After he got done with his work, he used to take the same route back and usually reach home at 11 p.m. when most of his family was asleep. He used to make this arduous journey for almost 20 years. The family used to see him only on Sundays. An active person even in his twilight after retirement from his government job, he worked in the private sector for another 22 years just to complete all his responsibilities, like the marriage of his children, till the age of 82 years. As you can imagine, because of walking 15 kilometers every day for 2 decades, he was one of the fittest 80-year-old you're likely to encounter. But as life would have it, and a surprise to everyone, he suffered a stroke in 2006. He finally left for his heavenly abode in 2007 at the age of 92. Today, 3 of his children are doctors. Dr. Rajiv Lochan and Dr. Lalit are founding members of EDPA, and one is an advocate. From his family tree today, there are a total of 15 doctors in many different specialities. 2 young doctors, Dr. Anirudh and Dr. Anubhav, are also the members of EDPA. Dr. Kriti, Dr. Lalit's daughter, has passed MD Dermatology recently. For his everlasting influence on his life, which still gives him a source of love, strength, and guidance, even today, Dr. Lalit has dedicated this oration to the memory of his loving father. So this year, Shri Om Prakash Khare Memorial Oration has been conferred to Dr. Dinesh Khullar. I request our Senior Vice President, Dr. Aman, to kindly escort Dr. Dinesh Khullar to the stage. I request the executives to welcome Dr. Dinesh Khullar.
Dr. Khullar, sir. I think Dr. Dinesh Khullar, you all know, is the, actually he's asked me to cut short his introduction. So we all know he's DM Nephrology, and he's the chairman and head Department of Nephrology and Renal Transplant Medicine at Max Super Specialty Hospital, Saket. He has numerous number of awards, and he has almost 75 publications in national and international journals. I welcome Dr. Dinesh Khullar for this prestigious oration, Shri Om Prakash Khare oration.
I request Dr. Lalit and Dr. Rajiv Lochan to kindly come over to the dais for felicitation.
And it's a pleasure that both the brothers are here, and I request Dr. Khullar to felicitate our Dr. Lalit sir and Dr. Rajiv Lochan sir. State note Raj Locha sir. Allah listen. I think it's a great moment for easily fishing switch, sir.
I request our executives to now felicitate Dr. Dinesh Khullar.
Request Khullar sir to the oration lecture and definitely will sit downstairs.
I request Dr. Dinesh Khullar sir to kindly start with the talk. It is going to be on recent advances in the management of renal anemia.
Good evening, ladies and gentlemen. At the outset, my sincere thanks to EDPA for this big honor bestowed on me. I'm really humbled and consider it my proud privilege to be the recipient of the second Shri Om Prakash Khare Memorial Oration. What an inspiring life journey of a noble soul we just heard, making sure that he was able to ensure top-class education to his children and make sure that his virtues and noble values were passed on. And what indeed a perfect way to let the memories live on and his principles and legacy carried on, so well done by his children. So it's, as I said, a matter of great pride for me to be talking in front of this august audience. And I have in particular chosen a topic which is close not just to a nephrologist's heart, but it's very relevant to each and every physician, doctor associated with the management of patients of chronic kidney disease. Why we are worried about the CKD is because of the fact, because the numbers are staggering. It's generally believed good about 15 to 16% of our Indian population is afflicted with chronic kidney disease, which makes it something like anywhere close to 20 crore of Indian population having chronic kidney disease. And if we believe there are about 10 crore diabetics in our country, good approximately 4 crore have a meaningful chronic kidney disease as a result of CKD. They have CKD because of various etiologies, diabetes being the majority of the reasons. So there have been recent advances in the management of something which is closely associated with chronic kidney disease, and that's anemia. We know the definitions of anemia, the same apply to anemia in chronic kidney disease as well, but this is normocytic normochromic hyperproliferative anemia, which we are so well concerned about in the context of chronic kidney disease. There are reasons to be scared of because it just increases the morbidity and possibly mortality as well when we look at the influence of anemia in the chronic kidney disease. But what we need to remember is that good 90% of these patients who reach a stage of dialysis are likely to suffer from significant anemia. Even if you look at very early stages of chronic kidney disease, about 15% as against 7.5% of those who do not have CKD is the kind of prevalence seen in these patients. So let's recapitulate before we move on. Why are we talking about anemia in the context of chronic kidney disease? Because we know that erythropoietin comes from the kidneys, but it's not just about erythropoietin. It's about all other factors which are applicable to people who do not have chronic kidney disease are going to be applicable to those who have chronic kidney disease as well. But here on one hand, we have the problems associated typically with iron metabolism, iron assimilation, iron absorption. On the other hand, we have reduced production of erythropoietin on one hand, and at the same hand, whatever production takes place is not able to have its desired effect because of the presence of so many toxins and so many confounding factors, such as hyperparathyroidism. There is hyporesponsiveness to the erythropoietin, whatever little the kidneys are able to produce now. And as I said, all those factors which apply to the general population would apply to our patients with CKD as well. So I'm gradually wanting to take you onto a journey which I personally have lived over the last about 30-35 years. I have been in touch with the field of nephrology. I really hoped and wished my mentor, my guru, my teacher, Dr. S.C. Chhabra, who initiated me into the field of nephrology way back in 1980s, was here to see how fondly I remember the days when we were taught by him. The only DM in the entire state of Punjab, forget about nephrology, but then of any other specialty, then for even a cardiology ailments, he would be the first person to be called. But he gave me a thesis which was on beta-2 microglobulin, a very progressive kind of thesis way back in 89 and 88, 89. No one had heard about beta-2 microglobulin in the context of hemodialysis, but then he had that faith, we will come out with something very useful. And I was equally delighted to see the examiner for that MD thesis was also here, Professor Vijay, who subsequently was my DM examiner as well. And he liked the thesis. Why I'm remembering those days is because in 1988 and 89 rather, erythropoietin had been discovered, was being marketed in USA, and we were privileged to have a dialysis unit in the city of Ludhiana way back in 1980s. And few of these people who were traveling from abroad will bring those tiny vials containing erythropoietin, and we used to wonder what this is. And it was a game changer, we realized very soon. Because in 1992, when Professor Chuk, and I am again privileged to be one of his last students, the famous legendary Professor K.S. Chuk from PGI Chandigarh, we were here from PGI to organize the Asia Pacific Congress of Nephrology in 6th of December 1992, and you would realize why I am mentioning this date. A lot of cancellations as a result of what had happened in Delhi then. But then we launched India's first erythropoietin in 1992 by the name Hemax. It was a game changer. We had released that huge big white balloon, I still remember, and it was a lot of fanfare. And we thought it was the end of the blood transfusions for our patients. We knew anemia was playing havoc with our patients' lives. We thought with the availability of erythropoietin to our patients, it's going to be a smooth sailing henceforth. Yes, it was indeed a game changer, But as is the case with many other drugs as well, there were shortcomings to erythropoietin as well. And I'll come back to that. And that is the basis of my talk over the next few minutes. So please bear with me when I'm going to talk to you about the absolute basics. As I said, I'm going to take you on a treatment journey for CKD anemia. As you can see on the left-hand side, nothing beyond blood transfusions. Then suddenly we realized we could give them iron dextran, and you will remember the kind of toxic effects associated typically with iron dextran. But still, in some subset of population, it was making a difference. Then finally, we came across erythropoietin, then the longer acting erythropoietin analogs like darbepoetin, and then finally sera. And then we realized they were not ideal kind of molecules. We needed something more. Comes in the recent concept of HIF-PHIs, hypoxia-inducible factor proryl hydroxylase inhibitors. So that's something which I'm finally going to take you through. Well, to briefly recapitulate again, when we are trying to address anemia in our patients, of course we have oral iron in mind, which is time tested. But the unfortunate part is, in a vast majority of our patients, oral iron doesn't suffice because of the poor absorption, assimilation for whatever reasons, some toxins which I'm going to refer to, some molecules I'm going to again refer to you about, are sitting in there which will not allow that to happen. So many times we need IV iron, especially when you give them erythropoietin, there is rapid mobilization of this iron pool. Oral iron is not able to cope up with that kind of load. You will need intravenous iron, and we have learned as nephrologists a whole lot about intravenous iron. Again, our journey, which took a change when iron sucrose was made available, subsequently ferric carboxymaltose, and now more recently we have isomaltoside. I was just told the name got changed to ferric derisomaltose. But yes, there are safer intravenous iron formulations available which have really helped the cause of anemia management in our patients. But before I start talking about HIF-PHIs, we still have to accept there will be some situations whereby out of compulsion we may still need blood transfusions even in 2024 in our patients with chronic kidney disease. So why does iron metabolism happen? Iron metabolism plays a role. As you can see on the left-hand side of the picture, the heme iron can get transported via the heme transporter into the cell, while the non-heme, that's ferric, the vegetarian form, needs to be converted into ferrous by duodenal cytochrome B, and then finds a way into the cell via dimellant transporter, DMT1. Now on the other side of the story, why I am taking you back to your physiology classes is with a reason. And as you can see, this ferroportin is supposed to take the iron from the cell into the bloodstream. Now our villain, so-called villain hepcidin, is not allowing ferroportin to do its work, and it is not allowing iron to get absorbed. So please, I will draw your attention to this villain, hepcidin. Well, God did not make it to be a villain, but in our context, in the management of chronic kidney disease, we are labeling it as a villain here. Now, before we move on, the absolute iron deficiency, which all of you probably know much more than me, than what I do, is applicable to our patients as well. Typically, low iron, elevated TIBC, and low ferritin will make it an absolute iron deficiency because of some loss or some poor intake. While on the other hand, what we as nephrologists see is more of functional iron deficiency. Iron is there, ferritin levels are normal, in fact they are supranormal, yet there is a situation of functional iron deficiency where TSAT, transferrin saturation, is low, and this iron is of no use to the body. To overcome that, we have devised strategies. We realized that one of the causes of this functional iron deficiency was chronic inflammatory state. Hepcidin was sitting in there, and we had to find ways to take care to eliminate the wrath brought in by hepcidin, and we will talk about that later on. So, before we finally go to the topic of the day, it is again trying to understand the importance of iron. It is of no use talking about erythropoietin or the newer molecules if your patient is not iron replete. So with that statement, let's move on. Whether intravenous or oral, there have been enough data which tell us that it is basically intravenous iron, especially in cases of those who have more advanced chronic kidney disease because of various reasons. But yes, when it is a pre-dialysis state, you can always repose your faith in oral iron as well. Only if it doesn't work will you want to move on to intravenous, especially when you know giving intravenous, especially to people, to call them to the hospital, because it is not recommended to be given at home. We all know, even though the iron preparations are absolutely safe these days, not absolutely, very, very safe these days, there is still a scope for some potential reactions. So KDIGO says, before you move on, ensure your patient is iron replete. With that in mind, let's talk about the great molecule which was launched in the world scenario in the 1980s. To us, as I said, became available in 1992. And it is something which we know what it does. It acts at the level of the bone marrow, having in effect on the progenitor cells, finally ensuring that they transform into erythrocytes under the influence of so many factors, of topmost priority being iron. Well, there have been various kinds of erythropoietins available to us. The short half-life of erythropoietin makes it mandatory to be given once or twice or thrice in a week, as compared to those analogs which have a longer half-life, like darbepoetin, typically given once in 2 weeks to 4 weeks. And then we finally have SERA, the methoxypolyethylene glycol derivative, which has to be typically given once in 3 to 4 weeks. So that's an improvement on something which came in with a lot of fanfare. And this is what the sacrosanct guidelines, which are followed world over by all of us, including nephrologists, have to say and talk about erythropoietin, and they every time remind us, please ensure that your patient's iron stores are replete before you talk about erythropoietin. Now the game changer again, one more time. We realized over a period of time that more is not something which is to be desired every time. We would typically believe and label a patient as having anemia, a male less than 13, a female less than 12, but when we tried to achieve a hemoglobin of 13 via erythropoietin, we burnt our fingers. I don't know whether I think it's visible from the distance as well, but 4 landmark trials, the normal hematocrit trial, the CREATE, COIR, and TREAT, cautioned us that if you try to reach a supra-normal level in your patients, you will burn your fingers, there will be a higher incidence of vascular thrombosis, strokes, MIs, cardiovascular morbidity and mortality. So we suddenly realized that we were not doing the right thing by aiming something like 13, 14 or 15. We realized that possibly 10 to 12 grams of hemoglobin was safe enough, was convenient enough. So, if that is going to be the case, why not try to eliminate the so-called problems with erythropoietin usage and try to evolve further? What are those problems? The increased viscosity and endothelial damage, increased platelet dysfunction, and hemoconcentration associated problems. Of course, you have to give very high doses of intravenous iron. You exceed ferritin levels of 700, 800 to up to ridiculously high levels of 1500, 2000. You're inviting hemochromatosis. So with that in mind, and at times, erythropoietin will not work at all. There is that element of hepcidin sitting, which is governing, not allowing iron to get inside. So what will erythropoietin do in the absence of iron? So with that in mind, we realize there is scope for something called HIF, hypoxia-inducible factors. Why do we believe when we go to the mountains, or those living permanently in the mountains have a higher hemoglobin? We know there is a factor which is induced by hypoxia, hypoxia-inducible factor, which is sensitive to oxygen concentration. So the same holds true for this. And for this discovery, 3 people were awarded Nobel Prize in 2019 for their research much earlier than that. Look at the importance of what the discovery of HIF has the way it has revolutionized. As you can see, in 2019, the Nobel Prize went to Professor William Kaelin, Sir Peter Ratcliffe, and Greg Semenza for their seminal work on HIF PHIs, or discovery of HIF. So I will now go slow, because this is going to be a very, very cautious journey henceforth, and I will want your complete and rapt attention, please, ladies and gentlemen. I think for the sake of our patients, we need to understand the newer concept of HIF PHIs. As you can see, the top panel says that when your patient is exposed to normal oxygen condition, normoxemia, what happens is, as you can see here, there is proryl hydroxylase domain, PHD, which responds to oxygen tension and to alpha ketoglutarate. What happens is, these things will stimulate, and PHD, the proryl hydroxylase domain, will cause the hydroxylation of HIF alpha. Now, HIF is something which was about to produce hemoglobin, was going to stimulate erythropoiesis. Now, look at what is happening. They degrade HIF alpha. There is polyubiquitination of HIF alpha, and it undergoes proteasomal degradation when oxygen is there. In hypoxic conditions, as you can see in panel B, or when you cause pseudo-hypoxic conditions, what happens is the PHD gets inhibited. Now, this proryl hydroxylase domain gets inhibited either via hypoxia or by giving them drugs called HIF PHIs. Now, what will happen? HIF alpha will not get degraded. HIF alpha now will get a chance to dimerize with HIF beta. The two combine, get translocated into the nucleus of the cell, and there is a cascade of events. There is transcription of many genes. Now, please, I will one more time draw your attention to what is happening under the influence of hypoxia. The HIF alpha degradation does not take place. It gets a chance to dimerize with HIF beta, and the transcription starts taking place. And what is that transcription? That is erythropoietin. But unfortunately, erythropoietin is not the only gene transcription that is taking place, and that is the cause of worry and cause of concern, because the proto-oncogenes, the genes are sitting right next, the vascular endothelial growth factor is sitting next, the cyst growth factors, the chloride channels are sitting next. So what will happen? Erythropoietin will get stimulated, there will be more of erythropoietin, but at what fear and what cost? There could be activation of oncogenic genes. You may get cancers, you may get retinopathies because vascular endothelial growth factor is getting activated. So these were the fears which we had in our mind when we started talking about HIF PHIs. Thankfully, 10 years down the line, because I have personally been associated with 3 landmark trials with HIF PHIs over the last 10 years, and the real world experience which we have in the last 2 years, it has not been confirmed. So moving on, this is in effect the overall ways by HIF PHIs work, not by just stimulating erythropoiesis, but also ensuring that the iron gets absorbed. And it also, that's the beauty, why I was talking about, why was I been mentioning repeatedly about hepcidin, because hepcidin was not allowing iron to get absorbed. HIF PHIs, they inhibit hepcidin, because as they say, there is a higher code for everything. If you have hepcidin and hepcidin not allowing iron to get stimulated, there is erythrophron sitting on top of hepcidin. So these HIF PHIs, they stimulate erythrophron and they tell, please eliminate this hepcidin. So hepcidin gets eliminated, and on both the accounts, iron as well as stimulation of erythropoietin, you can expect a good erythropoiesis. But there are other pleiotropic effects as well. Not just iron metabolism, but also something to do with glucose metabolism. It has been shown to be improved. You can expect LDL cholesterol to fall. You can get And mitigation, you can come across mitigation of acute kidney injury, renal fibrosis, inflammation. Why? Because everything gets mediated via HIF. So there are clinical benefits, why we have become so excited, but yes, that concern, that caution of what I alluded to will always remain, even it is still there. It will take some time before we can overcome that kind of fear, but so far, not major concerns. I will reiterate one more time, but look at the positives. The oral route suits all our patients, especially those who are not on dialysis. They don't have to seek help to get themselves injected. Increases or maintains hemoglobin levels quite effectively in a certain range. It is a physiological range of erythropoietin which is produced, and not the supranormal ranges which you may come across when you are giving very high doses of erythropoietin. I am quite flabbergasted at times to look at 10,000 units of erythropoietin being administered 2 to 3 times in a week. I mean, that's obviously inviting trouble. So, and of course, whole lot of other pleiotropic effects. So what are the different HIF-PHIs? As I said, I personally have been associated with the trials with both roxadustat, Olympus and Rockies, and then daprodustat, which was Ascend-D and Ascendant-D, and finally, matter of pride for all of us, an Indian company came out with a new chemical entity, Zydus came out with decidustat, which has been under various trials for the last 6 years, and now it was launched in the market about 3 years back, and it's done fairly well, and it's actually been a game changer. So what are the other factors, other things which we have in mind? You can expect mitigation of acute kidney injury if you are giving HIF-PHIs to your patients. There could be some cardiovascular protection, as you can see on the top panel, via reduction in myocardial ischemia injury, via attenuation of effects of angiotensin II. And that is again something useful for the patient. There could be a potential remission of atherosclerosis, direct effects, or via reduction of LDL. And also, you can expect some kind of neuroprotection to your patients as well. So it's not just about anemia. It's about managing their AKI, offering them cardiovascular protection, offering them neuroprotection. So what does the data say? All this was theoretical so far. So I have just sort of concised the whole thing for you in these few slides. Now these are the phase 3 randomized controlled trial data. 26 RCTs were analyzed, and where HIF-PHIs, the 3 ones available world over, except US, FDA has not approved except one in dialysis indication, whereby they were compared with the existing conventional erythropoiesis stimulating agents, and they were found to be effective in correcting anemia, and there were no safety signals. So before we jump on to efficacy, I think it's a safety which is of prime interest to all of us. Now, if you were to choose between the various molecules, be it daprodustat, roxa, or vedudustat, all these 17 trials said there is not much to choose from one to the other. All were safe, all were efficacious, so you can repose your faith. Coming back to what our own Indian data has shown via this DREAM-ND study, and which was with decidustat by Zydus in non-dialysis patients, they compared it with darbepoetin. And look what 1, 2, 3, 4, and 5 are showing here. One says the time to achieve target hemoglobin of 4 weeks was comparable. The percentage of hemoglobin responders was comparable when you compared the existing with the newer novel therapy. But the importance, look at the importance. LDL went down by 9.4 milligrams per deciliter, and hepcidin, which is not taken care of by the conventional erythropoietin, came down when we used HIF-PHIs, and of course, what we were fearing, the increase in vascular endothelial growth factor, the effect was not there. Same kind of data was with the DREAM-D population, that's those people who were on dialysis, and a combination of about 1,000 odd patients over a year's time showed that these drugs were very efficacious, comparable, and safe at the same time. And look at why we are interested in hepcidin. As you can see on the left-hand side, the reduction in hepcidin was remarkable. But when you compare it on the right-hand panel, that means patients are already on dialysis, the effect was not there, which means there is something more which has to be viewed in patients who are already on dialysis, which means we need to study it further. The sample size may not have been large enough. So this is our own data from our hospital, the real world evidence where we have shown that from baseline to within 12 weeks, you can expect hemoglobin touching around 10 from 9, and then finally it is staying at 20, even at 24 weeks at 10. And mind you, we're deliberating wanting to keep it between 10 and 12. We're not wanting it to exceed beyond 12. And this is data from other parts of the country as well. And this is a post-marketing surveillance study conducted by the company who have found, again, the drug is quite efficacious. Obviously, all these patients were already iron replete because we are not supposed to, as I've repeatedly reiterated, we are not supposed to go in for these expensive medicines till the time we have ensured that your patient is iron replete, a ferritin level of at least 100 nanograms. Now, one more thing where we try to see whether it can work. So many times we experience anemia, a significant one, even in our patients who are post-transplant. It does wonders there as well. There was data from roxadustat. Now, we have heard about some great stories about the newer molecules. But as I said, it is safety first and then efficacy. So what are the safety concerns? The safety concerns are, since it is going to stimulate many other genes as well, there could be some enhanced risk of thromboembolism, vascular calcification, heart failure may get precipitated or aggravated, risk of cancers, risk of aggravation of diabetic retinopathy, especially the proliferative form, and an increase in the size of those who have polycystic kidney disease. Also, another important thing, look at the positives which one can expect from a molecule called alpha-ketoglutarate. And I told you that by giving them HIF-PHIs, you are eliminating AKG. So AKG, alpha-ketoglutarate, has been typically associated with some great properties such as anti-aging, anti-osteoporotic, anti-inflammatory, anti-cancer, and protection against cardiomyopathy. So no, you are now taking away a very potentially useful thing. So you could have expected some problems. So this is like talking like a devil's advocate, and we must know that we are not harming our patients before we move on. And that's why it's taken more than 10 years to be convinced that all these fears were probably unfounded. The kind of dosage which we are using is not significant enough to cause any of these safety concerns. At least this is what the real world evidence is also showing the world over. It is being used, barring USA, in many other, Japan, China, Central Europe, so many other countries, and of course India. So the potential concerns, just to highlight one more time, are the safety factors as far as these few things I have tried to enumerate here. And I think, but again, to say that the adverse effects were in these meta-analyses found to be comparable. You name it, they had been studied, be it hyperkalemia, hypertension, cardiovascular disorders, or progression of kidney disease as well. Nothing was found to be of major concern. So with all this work, the guidelines have changed. The guidelines have started talking and mentioning about HIF-PHIs over the last few years. As you can see here, they say that anemia and CKD should be controlled using either ESAs or HIF-PHIs. They are talking about the two in the same breath, after, of course, sufficient iron supplementation. So these are the Asia Pacific Society Nephrology guidelines. The UKKA guidelines, which are again very important, they talk how best to use HIF-PHIs. So we have moved ahead from where we were struggling to say whether we should be using HIF-PHIs to a stage where we are now talking about how best to use them. And these are some of the the guidelines, which become very important once we start using them. And this also, the very important guidelines, the European renal best practice guidelines, they say, consider use of HIF-PHIs in the various categories of your patients, whether they are in the early stages of chronic kidney disease, whether you are dealing with your hemodialysis patients. Remember, our hemodialysis patients, contrary to what the data had shown, have a very high chances of having hepcidin because of the chronic inflammatory state that dialysis is all about. So giving them this useful drug at times does wonders. When we were struggling to alleviate anemia in our patients of CKD5D, HIF-PHIs were found to be a remarkable entry drug. And of course, they also tell us when not to use, especially when there is an active malignancy, when there is a very incidence of a cardiovascular or thrombotic event in the previous 3 months, when your patient has idiopathic pulmonary hypertension. These are the concerns before we have more data, on whether we can use it in the presence of mild to moderate retinopathy. I would certainly recommend not to use these drugs till the time we have safety data. So to conclude my talk, ladies and gentlemen, anemia is of common occurrence in chronic kidney disease and, as we all know, can have serious consequences. Its etiology is multifactorial. Iron metabolism on one hand, its absorption, assimilation, the hepcidin sitting in there on one hand, and erythropoietin deficiency and hyporesponsiveness on the other hand are the keys to effectively managing anemia in our patients. Discovery of erythropoietin was a game changer. I told you about what, with great fanfare, we had launched erythropoietin in 1992. Exactly 30 years later, in the same hall, I was talking about HIF-PHIs, and my introductory lines were, friends, I come here to praise Caesar as well as HIF-PHIs and not to bury Caesar, taking a cue from Julius Caesar. So which means there is a room, there is a scope for both these great molecules which have really revolutionized the way we look at renal anemia over the last 3 decades or so. HIF-PHIs, of course, are very promising agents, class of agents. They possess, as I've shown, many pleiotropic effects, not just anemia alleviation, also cardiovascular protection, AKI protection, neuroprotection, possibly role in various aspects of anemia, even post-transplantation. There are few, at least theoretical, big concerns, and we will be moving ahead very, very cautiously and all the time on the lookout for any of these safety concerns which I have shared with you. Thankfully, real-world evidence so far doesn't talk too much about any of these red flags. There is a real chance that the new compounds will be much more cost-effective in the long run, and of course they have the convenience of being oral drugs, and this fact will certainly improve the management of anemia, the quality of life, and hopefully also the survival of patients with CKD. With this, I end with once more gratitude from my side to the organizers of EDPA, as well as to the family of the great personality, Shri Om Prakash Ji, his children, Dr. Rajiv Lochan and Dr. Ladit. Thank you very much for this great honor, and once again, I'll take you.
So thank you, Dr. Dinesh Khullar, for a masterly oration, I would say. As a customary, we don't have any questions for you, but definitely we have the standing ovation for you, Dr. Dinesh Khullar, sir. Thank you very much, sir. Sir, you can have a group. I request Dr. Rajiv Lochan and Dr. Ladit to please come on for a group photograph. Dr. Ajay, Dr. Paras, Dr. Makkar boss, Dr. Aman, Gera sir, if you could come. Dr. BK sir. Dr. Ashok Kumar come, right? Dr. Rajivan sir. I think ये पूरा स्टेज हमारा भर जाएगा, लेकिन इतनी ओल्ड एसोसिएशन हमारी सर, 25 years हो गए. So Dr. Anki वो सर, बोलो सर, आ जाओ सर, अपना ही एसोसिएशन सर. I think it's an honor for us to honor Dr. Dinesh Khullar sir for a masterly oration, I would say.
This is the 25th year EDPA, silver jubilee. Big honor, big honor. I am missing both my Guruji to left little early, Dr. left, Dr. Kher left.
This will be a very huge memory, sir, for our association for 20.
Big honor, I'll have these Paris Nandi
So we'll be at the 25th